Okay, so good morning, everybody. My name is Dr. Zainab Yunusa Kaltungo. I'm a plastic surgeon with Federal Teaching Hospital, Gombe. I'm the coordinator of the Biomedicine and Healthcare Online Journal Club, supported by AuthorAid International. Today, we're doing a relaunch of our journal club. Our journal club has been in existence for about 4 years now. We're doing a relaunch, and what this relaunch means is we're going to reactivate all our activities, but with a little extra fire to it. And I'm happy to say that I have two wonderful colleagues that will be coordinating the journal clubs with me. First person is Dr. Daniel Maina. He's also a plastic surgeon. Dr. Maina, if you could just, if it's possible to, let's see your video so they can know you. And also assisted by Dr. Akima Toebi. He's also a plastic surgeon. Yes, we're keeping it within the family. So, so what are we to expect going forward? We're going to have more regular activities, hopefully every month now, or even more frequently, depending on the situation. Then in addition, the activities of the journal club will be incorporated somewhat into the activities of the National AuthorAid National Research Hub that has been hosting a lot of activities, including the 3-day workshop on data science that ended yesterday. And some of the activities I would really love us to participate in are one, I'd like members to suggest articles from their specialties. I've heard a lot of people outside core medicine telling me that the discussions are lopsided. All of them are within the medical field. And I've told them to submit articles. Nobody has submitted any article. All the articles that have been volunteered have been by the physicians. We do not want it like this. We want an all-encompassing one, because remember we said biomedicine and healthcare. So even if you're in biomedical engineering, you're relevant to this journal club, and we really like to have you. Then in addition, I'm happy to announce that apart from our in-house data guru, who unfortunately cannot make it today, Dr. Emeka Felix Ayam, we have 3 other people who are going to be more regular here. One of them you must be kind of familiar with. There's Dr. Babashani. He's a vet surgeon based in Northeast Nigeria. Then we have Asamu Alabi. He's Ghanaian. He was there at the last journal club. And then we're also going to have Mr. Jeremiah Agada. He was a resource person for the data science workshop that we held on the 27th, 28th, and 29th. The last one was yesterday. And for everybody who was present, you can attest to how good he is with what he does. Then we're also going to reactivate our Shut Up and Write co-working session. It's been found internationally to work. You're going to dedicate time. We decided we're going to use 2 hours, weekends. I'll send the details to the group again for those who don't know about it. We just sit down and write. We'll decide if it works with everybody to turn on our videos, but there'll be no talking. You're just working on your research project. For those who are still students and trying to do their thesis, use those 2 hours, and then you send us feedback on what you have been able to do. For those of you who are members of the either Africana Journal Club or the Social Sciences Club run by Drs. Aurelia and Joyce Wangari, they've been doing it very regularly. We started, but we had to stop because I didn't have enough assistance and it was a bit overwhelming for me. So we're hoping to rejuvenate that. Then in addition, we have quite a number of resident doctors like Dr. Mubarak here, he's a senior registrar in orthopedics. And as part of requirements for him to complete his training in the fellowship programs of the postgraduate medical colleges, he's supposed to do a dissertation. And that's one of the things we're hoping we could help people with. One of them is that if you're having a problem, even with just your research design, you can bring your idea and then you're going to get into an international audience to help you contribute and mentor you. What if you've already put the proposal together and you want somebody else to have a look apart from your supervisors? We're very happy to do that. And what if you finished the you finish sample collection, you finish your dissertation before you submit and go for your exams, you can come for what we consider a mock defense. So you can come for that too. And I'm happy to say that ever since Mr. Felix Emeka started helping the residents in my department, a lot of them have had their proposal and even their final thesis scaled through without any hitches. It's kind of like a first in our department. So it is helping people, and we're hoping we'll get a lot of people submitting and volunteering. The last journal club, if you remember, was Dr. Ajayi, a senior registrar in neurosurgery, who presented his thesis. And as you can see, he thought he was done. A lot of his supervisors had already made input, but he got a lot of valuable input. And you can never have enough good eyes looking at your work for you before it goes forward. So having said that, thank you. Now we have Dr. Maina. This is Dr. Maina, and he's going to be one of the coordinators. Thank you very much, Dr. Maina. As I said, he's also a plastic surgeon. Dr. Atoibi, if you're not camera shy, can you let us see you so we know who, when we see your post, we know who is posting. Okay, maybe he's camera shy. Excellent. So that's him. You see, we're all very good looking people. That's why we're plastic surgeons. Thank you. So without further ado, if there are any questions or comments about what I've just said, we can close this lunch and go into the business of today. So, any questions, comments? Questions, comments? You can unmute. I think I've allowed everybody to unmute. You can unmute and speak. Or just put a question in the chat box. All right. So looks like our people are camera shy. So, all right. So without further ado, and if you do have questions and you do not want to post them here, please, you can put them on the group, on the WhatsApp group, and then we'll be responding. So this is officially the end of the relaunch, and then we can go on to the journal club of the day. Dr. Mubarak, please go ahead and continue sharing. I'll just give you back host. I had to do that. I thought it would, I'll make you back host. See if you can continue sharing, but if it doesn't allow you share, then I'll make you back host. And I mute myself. I've talked enough now. Thank you. Fantastic. Is he allowing you share? I'm muted. No. Okay. All right. So let me just give you back host. I don't know. It said I could make you. Mubarak Yusuf. There you are. Good. I think you can go ahead now. Thank you.
Okay, I can go ahead now. Okay, good morning, all. I'll be presenting a review of the journal, which title is "Honey Dressing: A Missed Way for Orthopedic Wound Care." The journal was the article was published by Ahmed A.E. Eltregi S. Kandi M.I. and the name is Honey Dressing: A Missed Way for. Sorry, let me mute my notifications. A Missed Way for Orthopedic Wound Care, published in the International Orthopedic Journal of International Orthopedic 2022, the volume 46. The study was conducted between January 2018 and April 2020 at the Department of Orthopedic Surgery, Benha Faculty of Medicine, Benha University, Egypt. As an introduction, the orthopedic-related infections are known to significantly increase morbidity in orthopedic patients. They are better prevented than treated, and a significant step in reducing orthopedic infections is the care of orthopedic-related wounds. Honey enhances wound healing through all its stages, through the inflammatory stage, proliferative, and the consolidative phases. It has been shown to have successful results in many wounds. However, there is limited data reporting the use of honey in orthopedic-related wounds. The authors sought to evaluate the efficacy and safety of the use of honey as topical care for orthopedic-related wounds with limited resources. The patients and methods, it is a prospective study that was conducted at the Department of Orthopedic Surgery of the Ben-Hur Faculty of Medicine. Patients with leg and foot wounds, such as open fractures, postoperative wounds, complications, and infected tibial non-unions were included in the study. Patients who refused honey as a method of wound care, patients with peripheral vascular insufficiency, and cases that were missed during follow-up were excluded from the study. The study included 50 cases with an average age of 38.18, with ranging from 17 years to 63 years of age. The locations of the wounds were in the leg in 41 patients, foot in 6 patients, and ankle in 3 patients. The original cause of the wounds was open fracture in 34 cases, that's 68%, infected tibial non-union in 9 cases, postoperative infection and wound dehiscence in 7 cases, in which 4 were after internal fixation and 3 after Achilles that were related to Achilles tendon wounds. The open fractures involved the proximal leg in 4 cases, middle leg in 16 cases, and distal leg in 8 cases. And then it involved the foot in 6 cases. According to the Goslow-Anderson classification of the open fractures, there were 9 cases of grade 2 injuries, and then grade 3A injuries had 9 cases, and then patients with grade 3B injuries were 16 in number. Tibial non-unions were distal in 6 cases, mid-tibial in 2 cases, and proximal tibial in 1 case. Bone was exposed in 2 cases. The same thing with tendon was also exposed in 2 cases involved in the study. There were 21 smokers and 6 patients with diabetes, and no other cause of immunosuppression was present in the study. Besides the wound care, the primary cause was handled individually. So the non-unions were handled individually. The open fractures were also managed individually. As for the dressing technique involved, it is commenced after the debridement and treatment of the case and optimization of the patient. The dressing is done by the patient or relative at home after being taught initially by the doctor in the hospital who will teach the relative, and then they will carry on at home. And then subsequently, during every visit, they are asked to repeat the dressing in front of the authors to ascertain how well they are performing the dressing at home. It was done by washing with saline, then a gauze soaked in honey was applied. No antiseptics were used in this study. The amount of honey, gauze, and frequency of dressing varied according to wound size and amount of exudates from the wound. And then systemic antibiotics were given for 4 weeks. For assessment and follow-up, the patients were followed up weekly until sound wound healing, and then they are followed up monthly until the treatment of the underlying cause. As with most orthopedic cases, the underlying causes usually take longer to heal than conventional wounds, and even in abnormal wounds. So the parameters assessed were wound size, depth, discharge, granulation tissue formation, epithelialization, condition of adjacent skin, adverse events, and time to complete wound healing. Photographs were taken for documentation, and radiographic follow-up of the orthopedic condition was also done. The results gotten after debridement, skin closure was possible in 10 open fractures, 7 infected non-unions, and 2 open Achilles tendon wounds. Other open fracture wounds ranged from 8 to 20 centimeter longitudinally and 3 to 17 centimeter horizontally. Postoperative cases and 2 non-union wounds ranged from 10 to 13 centimeter longitudinally and 3 to 5 centimeter horizontally. In addition to the infected non-unions and postoperative complications, 13 cases of open fractures needed debridement, and deep samples were taken during debridement of these 29 cases that needed the debridement and were subjected to culture and sensitivity testing, in which Staph aureus was cultured in 12 cases, Staph epidermidis in 7, Klebsiella pneumoniae Pseudomonas aeruginosa, and even methicillin-resistant Staph aureus was cultured in 2 cases. All cases showed improvement on follow-up with complete wound healing and bone coverage, except in 1 case, and then there was also complete tendon coverage. Duration of wound healing ranged from 4 to 15 weeks, which depends on the wound size. Recurrence of deep infection occurred in 3 cases, necessitating redebridement in these cases. The exposed bone in 1 of the cases was excised and final bone coverage was achieved. The second wound healed, but persistence of sinuses necessitated implant removal. The second wound with the exposed bone is a case of a tibial non-union, and then the implant was removed due to persistence of the sinuses despite healing of the wound. Exposed tendons showed necrosis and superficial debridement was done, which then later the wound went on and it healed. Initial itching in the first few days of commencing dressing in 5 patients is the only side effect encountered during the study. The authors followed the principle of wound care, in which the wound dressing is not considered a substitute for indicated debridement. So in cases where there is indication for debridement, as mentioned earlier, they have gone on and performed those debridement and redebridement in the course of the study. The rationale for the study was previous documented evidences showing good results with different types of wounds, such as Fournier's gangrene, bone wounds. However, due to limited data on orthopedics-related wounds, the study was now performed so as to get more data on orthopedic-related wounds. Broad-spectrum antibacterial activity of honey, as documented by previous study, is further buttressed in this study by continuous healing of the wounds despite discontinuation of antibiotics. And this is seen even in methicillin-resistant Staph aureus in this study. The study demonstrated the efficacy of honey on healing of different orthopedic-related wounds, even with bone and tendon exposure. The limitations of the study that the authors were able to find out to express was the small number of cases involved. Only 50 cases were studied, and when it comes to wound, a larger number of cases would have been better. And then the lack of controls. And the study is a prospective study, so they did not really have controls to compare. And there is heterogeneity of the wounds. It will almost be impossible for the authors or anyone else trying to conduct a similar study to get wounds of the same size, the same physiology, and the same background pathology to compare. So that's one of the limitations in this study. And then the inability to ensure the consistency of honey, to ensure that the patient's relative is using the same type of honey during the course of the study will have been very difficult for the was difficult for the authors of the study. Sample size was not determined prior to the study, and hence statistically significant conclusions could not be derived. The cost was not compared with other types of dressing in the article. So the some critiques I'm able to express are the title. I feel the title is not specific. The samples involved only consist of leg and Achilles tendon related wounds, and the titles talked about dealing with orthopedic wounds, and leg and Achilles tendon wound is just a part of wounds, like just a part of wounds that orthopedic surgeons deal with every day. So I feel it could have been more specific to specify that they are dealing with lower limb wounds, related wounds. And then the manner and compliance with protocol of dressing at home could not be ensured. The patient, yes, even though they monitor the dressing done by the relatives in the hospital, but the relatives might not really keep to the dressing at home, or they might not really keep to the protocol that was shown to them. And this will not be, cannot be ensured by couldn't have been ensured by the authors of this article. Then secondary wound cover, I feel, would have been better for some of the patients, rather than subjecting some of the patients in which their wounds took as long as 15 weeks to heal. I feel if deep infection have been controlled in some of these patients, skin grafting or flap where indicated will have been better in speeding up the process of the healing of these patients, rather than subjecting them to longer periods of dressing with the honey. Then the use of other adjuncts to wound care was not mentioned, such as vitamin C, zinc, and immunomodulation, for example. Nutrition was not really mentioned in the study. So we don't know whether they are what plays a role in healing of the wound or not. So that is not very clear in the article. Then the sizes of two exposed bone and exposed tendon may be small to draw conclusion on the safety of honey on these structures. Previous documentations show that honey is hygroscopic in nature and might lead to drying up of exposed bone or tendon. So, and this study showed that the use of honey is even good for exposed bone and tendon, but I feel only 2 cases of exposed bone and tendon is not enough to derive conclusion that this is very safe. And therefore, more work with larger sample size and standard and near standard conditions will need to be done to really confirm the safety of honey on exposed bone and tendons. And then while the endpoint is complete wound healing, there may be some bias to clinical assessment of wound, which may be performed by different people in the course of the study. Thank you for listening.
Thank you very much, Dr. Mubarak. That was really concise. So now we can take questions and comments. I don't know why I thought I've allowed everybody to unmute, but I'll just do that again. Let's take questions and comments. I have a few of mine, but I think I'll reserve them until the end. Questions, comments, everybody? I've allowed everybody to unmute, so you can just unmute and ask your question. Our fellow plastic surgeon is here. Yes, I know you have a lot of questions. I have a lot too that are related to the not the technicality of the paper, but the clinical aspect. Yes, please, Dr. Akintayo, please speak.
Good morning, everybody.
Morning, Dr. Akintayo.
When the wound is involved, I thought it's supposed to be multidisciplinary management, which was not stated in any of the research. At least other units that are involved. Even the patients that are diabetic, the endocrinologist is supposed to be involved. As the referral said that other adjunct treatment was not mentioned. The other modality of management that could be used, VAC, that could be used if patients have to manage with other specialties. I think that's just a problem I see in the study. And that's one. The second one is about, when you talk about does the size of the wound influence the time of closure? I mean, how do you relate the size to the duration of the wound? I mean, there's no association, there's no expression of, there's no documentation sure about how the size relates to the duration of the wound. And how long will they wait before the wound, or maybe second wound closure is done? If you have a fracture, some of them may actually offer a early wound closure, which will preclude this extent of dressing. So the role of other specialties is not clearly listed. Thank you.
Thank you, Dr. Akintayo. In fact, you're being very kind. A lot of the questions I have about the patient care, let me keep them for now so I don't bias anybody's mind. There's somebody in the comments, somebody's commenting, Dr. Mubarak, that you're a good presenter and that your slides are good. You were concise and precise. Well done. So any more questions? Please unmute and speak if you have any more questions. Maybe we should tell the plastic surgeons to hold on before we go straight into, before we turn the discussion into plastic surgery. We'll tell the plastic surgeons to hold on for now. So any other questions, comments? Questions, comments? Dr. Mubarak, do you have any response to the point raised by Dr. Akintayo? Dr. Mubarak, are you still there? I think you're muted. I hope the network has not thrown you out. Please unmute. Okay, good. Yes. Do you have any questions? Yes.
Yes, no, it's just a comment. As regards to the size of the wounds, it's an area of concern really, because they were very vague in mentioning that the duration of the wound healing varies according to the wound size. but they did not really directly relate to the wound size, showing that, okay, larger wounds take longer. That was not very clear in the article. So same thing. And then the issue of multidisciplinary management was not mentioned at all in the article. Just the authors were just mentioned, and then the process of the wound healing. But any other management, any other steps or management or other disciplines involved were not really mentioned.
Yeah, I agree. Any more questions, comments? Please unmute. If you can't unmute, just raise hand and then I will unmute you. Questions, comments? Okay, I'm lifting the embargo on plastic surgeons commenting. Let the attacks begin. I'm sure my colleagues, Drs. Maina and Dr. Tebu, will have a lot to say. Please unmute and speak. Two participants have raised their hands. Okay, there's Osho Suleiman Adeniro. So please unmute and speak. I've asked you to unmute. Please go ahead.
Hello, good morning, ma'am.
Morning, how are you? Please, short introduction so we have an idea. Good, thank you.
Okay. So my question is that, I just want to know if the authentication of the originality of the honey was carried out by laboratory analysis and the likes, because we have so many adulterated honey. So I would like to know that, because though I'm an MSc student of public health, at the same time, I also practice natural medicine.
Okay.
I learned it locally, and I've used honey severally to treat wound and some medical conditions, and I know it works. But the major problem about honey is getting original honey.
Yes.
So that's why I want to find out if it was authenticated.
Okay. So Dr. Mubarak, would you want to respond to that? I think the authors actually made some clarification, but let's see if the reviewer has anything to say. Dr. Mubarak, are you still there? I've asked everybody to unmute. I don't know why people are unable to unmute. Dr. Mubarak?
Okay.
Yes.
Yes, ma'am. Yes, the authors pointed out that medical grade honey will have been, the quality will have been ensured with the use of a medical grade honey. But then they were not able to get access to medical grade honey because of how expensive and inaccessible it is, probably in their own environments. But then another concern that I also had during the study is I think they should have used a specific source of the honey to ensure its quality and then the homogeneity of the type of honey being used, which was not done by them during the course of the study. So possibly different honey from different sources, and then they did not try to authenticate the honeys that were employed during the study.
Yeah, I agree. Okay, so Dr. Maina.
Good morning.
Morning, doctor.
Yes, thank you, Dr. Mubarak, for the very nice presentation. I'll just go straight to the issue of exposed bone. In the article, they said two cases. There were two cases that had exposed bone. And going through the article itself, we see that both cases of the patients that had exposed bone actually had the bones desiccated. So I'm just wondering, the final conclusion vis-a-vis the issue of honey being recommended for orthopedic wounds, non-exposed bone. So I don't know if you have any contribution to make regarding that issue. Thank you. I think I'll hold on to the other questions and let them be.
Thank you so much for that, Dr. Mubarak. Would you want to answer? Dr. Mubarak, are you still there? I've asked everybody to unmute. I don't know why I think it's probably my network. Unmute. Good. I hope I didn't mute you back. Yes, go ahead.
Okay. Yes, thank you, sir, for the contribution. They pointed out that they had to debride some of the exposed bone despite the use of the honey. But I don't know, for some reason in their own conclusion, they now pointed out that it's good for orthopedic wounds, even with bone exposure. So that is one of the issues I have with the study, actually. Since
What's your
obviously there
problem
is
with
some
it?
problem.
Okay.
And obviously there was some problem with the use of the honey on the bone, but then the conclusion is saying it is safe for the use of honey. So are they recommending that we go ahead and use the honey and then the bride as they do themselves, or and that's what I don't really get from what they are saying in the study.
We actually sent them an invite, but they didn't join. So what will happen is that I'll send them a link to the recording in case they want to address some of the questions. Then you can email us and I'll post the responses. We've done that before. Okay, all right.
Dr.
So
Mubarak.
Yes, sir.
Sorry, man.
Go ahead,
Let me put a ripple in your answer a little bit, because they did not say that it was during the course of honey that the patients had exposed bone or desiccated bone, for that matter. Particularly for one of the two patients, the major patient that they discussed, that was the one that was in figure 3. I would have loved if you had put up the pictures that were involved. This patient outrightly had desiccated bone when even the first picture that he came, he had desiccated bone, and they just continued dressing. So the author didn't tell you that it was the honey that caused desiccation. But what they're telling you that in the course of the use of the honey, that the state of the wound improved. Now, in during the course of discussion, they talked about a patient having sequestrectomy, which I would like to think is one of those patients, but which they didn't actually link directly to the patient, that this was the patient that had sequestrectomy, because one of the bones, one of the pictures, the bone was actually looking desiccated. So it wasn't, they never told you that it was the honey that was causing it. So what they said that they now used honey and the wound got better. So you can't say that it is their honey that caused the desiccation.
So this patient, right? This is figure 3. Dr. Atoyebi, this patient? Okay, I think he's muted. And I don't know why this thing will not allow him.
Even figure 1.
Okay, all right. Yeah, there were a lot of things hidden in the discussion. It was not very, they were not very specific with a lot of things that I would have wanted us to know about. Okay, this is figure 2. Let's see figure 1. All participants, if you could just mute, please. There's a lot of background noise. Please mute everybody. Thank you. This is figure 1, right? I think so. I think this is 1. Yeah, this is figure 1. Yes, all right. So, any more questions? I saw somebody raising their hand. I think it was Choma. So I'm going to have to stop share. I don't know what is wrong with my system when I'm sharing. I don't see the controls well. Okay, there were 2 hands up. Choma, I think I allowed you to mute. Or was it not Choma? So it's Abella, it's not Choma. Abella, please unmute and speak. Abella, I think is a pharmacist.
Yeah, good morning, everyone. And
Morning,
thank you, Dr. Zainab, for the opportunity. I'm a clinical pharmacist, or will I say public health pharmacist. And this is actually my first time attending this journal club or the journal club activities. So I believe what we are meant to do for this manuscript is like to point out, I would say critique the paper. Well, my observation from this journal, published journal, when I was reading it, I don't know whether it's because of my background, where I'm coming from, a clinical pharmacist, and the way research methods has been transferred to some of us in the clinical section. When I was reading, the first point I noticed in the manuscript is that under patients and method, that was even the first time I'm seeing patients and method, which might be different. That's why I said it might be my information now or informed, how would I put it? What I have at the back of my mind when it comes to manuscript might be because of my own background. Because I looked at the methods, to me, they were appearing as if they were results. I'm seeing percentages and cases and all of that. And I was thinking that could be better way of presenting your methods. Because I looked at table 1, I was asking myself, is this still part of method, or the author is presenting the results already gotten somewhere? Or I got a little bit confused because I looked at the table 1 and I'm seeing analyzed data. And I'm asking myself, is this one part of the method? Is it part of selecting the population for the story, which I think there are people with wounds and all of that? What I have or what I know is that in methods, you start off by stating your study setting, and then you clearly state your study design. And that there will be a column or a section for data collection, or maybe patient information and data collection. In that order, it gives people like us. I'm not an orthopedic surgeon. I haven't done anything bone related. I'm just seeing this kind of a manuscript for the first time. So that's why I had to quickly explain my background, where I am coming from. I'm not saying that it's totally wrong. It's possible that is the way they write in this field. But in my own field, in my own field where I'm coming from, when you get to method section, you clearly state where this study was carried out, what is the study design. Is it a cross-sectional study? Is it a prospective study? Is it an interventional study? You clearly state it so that you lead whoever that is getting in touch with this manuscript. And then you move further to explain what you did, data collection. How did you select your patients? Are they, for me, my area is modeling and diabetes adherence and whatever. You state how you selected your sample. What are the peculiar things that differentiated the people you used in your study vis-a-vis the one you dropped? Those are the areas you explain your population and the people you worked with. And then you talk about inclusion, exclusion, and then your sample size determination. Because when the presenter, good presentation though, he stated that one of the limitation was that sample size was not calculated or was not determined. And on my own, I felt that is not a limitation, because it's something the author, the researcher should do. It's part of the research method. You must determine your sample size. Limitations are the things you encounter when you go on the field. You are about collecting your data, maybe because there is lack of data, records, people did not provide you, the things you met on ground. So that's why I said maybe the writing for some of our colleagues here is a little bit different from what I know or the way we write our own. But at least when I didn't have time to go through everything, but I went through the abstract. And the first thing that occurred to me, or I noticed, was is as if, is this method or result? Which of course I said, maybe I'm going to ask. Maybe that's the way they do their own presentation when they come out with cases like this. So this my little observation. Maybe you guys will clarify things for me a little bit more. For us, we separate things where I'm coming from. Or the
Thank you
presenter
so
did a
much.
good job, a concise presentation. But that's just my little observation. When I looked at the method, I thought, are they results or a combination of results and method? But of course, it was clearly stated that these methods and patients.
Yes.
So maybe further clarifications can help me out. Thank you.
All right. So thank you so much. Very, very, very valid comments. Dr. Mubarak, do you want to respond to that? I'm very happy to see that Mr. Agada is here, so he's going to come and scatter this data part of it for us. So keep all your data questions until he's spoken. He might resolve your comments. Dr. Mbarak, please tell me you can unmute. Do you have any questions, comments? I don't know why this thing is not allowing. I've allowed everybody to mute. Dr. Mbarak, questions? Do you have any response to what she said? Or you want to leave it for our guru to respond?
I think I'd rather leave it for our own epidemiologist.
Okay, all right. So, but did you respond to Dr. Atoyebi's observation? Dr. Barak, did you respond? Okay, looks like I'm alone here. Can you hear me, please, or has my network thrown me out? If you can hear me, please just post a thumbs up in the chat box.
We can hear you.
Okay, thank you. Thank you. Any questions? Did you respond, Dr. Mbarak? Did you respond to Dr. Atoyebi's observation? I'm sorry, I remember. Okay, you're muted.
Yes,
You're
I think
muted,
so. I
right?
think he just made a comment more of.
Okay. All right. So I know Dr. Mena wants to say a lot, but Dr. Atoyebi just, okay, I think maybe he's not happy with your response. He wants to say something. Please unmute, Dr. Atoyebi.
Okay. Well, it wasn't really to say something to what he has said, but since he has said that he will let our in-house statistician answer the question, valid observation that was raised by the pharmacist. So I think I'll just keep that till he answers. There are still a couple of things to say about the article anyway, but
yeah, lots to say.
I was not going to say anything to what he said.
Okay, all right. So was there any other hand up before Mr. Agada's own? Because there was one other hand up, and then okay, sorry, Dr. Said, I know you posted your comments, but I really like you. I like what you have, I like the points you raised in the chat box. Please, I'll let you unmute and speak. But if you'd rather I read out your comments, I can do that too. Fantastic, thank you. Please speak, Dr. Kenny. Dr. Said, and please, short introduction so we'll have an idea of your background.
Okay. Good morning, everybody.
Morning.
It's a pleasure to be here. I'm Dr. Akoni. I'm general surgeon.
Okay.
It's my first time on the page too. I always follow the AutoAid post. Thanks for the lovely critique on the paper. I just saw so many things. While it's an attempt to add to the literature, but they didn't go too much into details. They were not. I don't think they were meticulous enough. Considering the controversies or considering the reservations with using honey, especially when you're treating exposed bones, I think they should have done more in terms of having a uniform source of honey for all patients. The gauze they're going to use because of the infection, the multidisciplinary care and involvement of those people, and all those details should have been exhaustive. And not only that, the heterogeneity of those injuries, Gosling Anderson 1, Gosling Anderson 2, Gosling Anderson 3, is not the same treatment. And like somebody commented, you cannot be dressing wound for 15 weeks when the patient could be better served by secondary closure. So I think all those things point to areas where we could have done better. So that's just my take, that we should have done more due diligence and to have made the paper more standard and more competitive. So it could be a reference point when we are talking about honey wound dressing for bone, for such injuries. Thank you.
All right. Thank you so much. I 100% agree with you. So now let's go to Mr. Agada. Mr. Agada, I think I will allow you on mute. Good. Please unmute and speak.
Okay, good morning.
Morning again.
Yes, I think I'm audible now.
Very audible.
Okay. Quickly, let's just look at the data, the result. I mean, if you look at the result, there is no connection between the result and the title. The title is Honey Dressing, a Missed Way for Orthopedic Wound Care. If the researchers wanted to make it so clear, they would have done, there are many things they would have done. I want to believe, when I was reading this, I want to believe that this is only a part of their research work. There are people that just choose to present only an objective, but in it's really not giving any information. I was expecting that they were going to do a comparative study, kind of, because you cannot tell us honey is better if you have not told us what other people have used and then compare. Then I was expecting also to see something like time. How many days did it take to use honey? We didn't see on the, yes, I heard something like 15 days, but I was expecting to see them, okay, tell us this particular disease problem or this particular side of fracture took so and so number of days to heal, or and then on this particular, I don't know, the honey itself, somebody was asking, was it pure or was it was it mixed, kind of, does it have anything in it? That's one. Then if they are looking at the data, that's the research that's looking at it. When we look at the data generally, you cannot just present uh, uh,
Okay, go ahead, Mr. Akada, or is it your network? I think his network has thrown him out, or is it me who's been thrown out? Okay, okay, all right, go ahead.
Frequency and percentage, and you can't get any serious
Uh-oh.
In progress.
Uh-oh, the network. I'm missing out so much.
Okay, hello, can
So,
you hear me now?
Now you are back. You were off for a while. Go ahead.
Yes. Okay, but okay, everybody can hear me now.
Yes, we can hear you now.
I was looking at the data or the results that were presented, and then looking at it, you cannot just give a vivid conclusion. You cannot tell me and say honey can do better when you have not told me what another has done. Now, I was looking at the infection area. What infected these wounds? Did they check for the bacteria or whatever the pathogen that caused the infection, whatever it is? They didn't present these ones. They would have presented those infection causing agents, and then they would have also told us how many days the honey took to eradicate this, for you to make me believe and accept statistically that these honey, the honey rather, can help in healing, wound healing. So we want to know how many days, or would have known how many days it would have taken, then compare with other source of wound healing. Sorry, I'm not in the medical line, so I'm trying to present it the way I best can present. So they would have told us some of these things, and then allow statistics to now show us a level the honey, if it now so happen like that, if it so happen like that, then we can now say honey is the best along that line. But we cannot just accept. Somebody was one of the persons that reviewed said 15 days. You take 15 days to heal the wound with honey, whereas there are others that would have done better. So in that case, honey cannot. So that topic is faulty. Possibly they would have said, they would have readjusted the topic to be a prevalence study, kind of, with a little honey. That would have been better, because the result here is really not presenting anything at all. And there is no statistics here. Sincerely, there is no statistics here. And so we cannot conclude on anything. We cannot accept the conclusion that has been presented already. So thank you. That's just what I want to present now.
Thank you so much, Mr. Agada. Mrs. Salisu's hand is up. Mrs. Salisu, please speak. Please unmute and speak.
All right. Thank you. It's another wonderful interaction going on here, and I begin to learn from so many people. I'm getting more interested and interested. All right. So for all the young ones like us in the house, please let us take note of this when we're designing our projects and when we're carrying. I want to believe we'll be rolling out more sophisticated publications after this whole review, seminar, statistical knowledge that we've gained here. Having said that, I just, before Mr. Agada came here, I wanted to talk about the topic myself. The title, it was just too contradictory, because if they said that is a missed way, which we all know that we use honey, even at home when we have fire bunch or hot water, and we quickly put on a weed that we are familiar with what we do in the kitchen. And now the title said a missed way for orthopedic wound care. If it's a missed way, that title is saying that is a contradictory message, telling the orthopedic practitioners to stop using honey. That is what I got from the topic. Then I went down to look at the assessment. I'm interested in the result and the conclusion. I've read the conclusion. I looked at the assessment and follow-up. And I saw all these criteria, clearance of discharge, progression, whatever, and I didn't see it in any table. And like Mr. Agada said, I went back to the table and I was like, there is no any informative statistical knowledge from the table presented on the location, causes of wound. I don't know. The all criteria here listed under assessments and follow-up were not in table formats. And talking about the bacterial infection, it might not necessarily be their area. Sometimes because of different areas, I want to look at that side of maybe that side belongs to those in microbiology part and what have you. But if it's strictly orthopedic, they want to focus on the tendons, the bones, the healing, and what have you, which I was going to say it would have been better to present the table in that format of all these criteria listed under the assessments based on the time progression of healing, whether in hours, in weeks, in months, aside the bacteria, and compare, like you said, might not necessarily want to compare, they might want to give us maybe a kind of discovery, or they might want to just tell us, oh, maybe the duration to which honey, heal those wounds as supposed. But I mean, if they want to compare, it will have been much more robust to compare with what they normally use in hospitals, what the orthopedic practitioners uses then as compared to honey, or if they have been using honey and now a faster way of using the honey to heal the wound. That is just I saw these as in the couple with different comments and a lot of reservations. I saw this as a kind of a review, and no any form of statistic. They could have just made it a kind of a narrative review, because they have a lot of pictures and they don't have any statistical relevance to the title. That's just my view. Thank you.
Thank you, Mrs. Salisu. And everybody, is there any more? Do we have any more comments before we start? Before we go into the technicalities of the clinical practice of this? This is probably the first article we're reviewing that has been torn apart by everybody. So it's good. We shouldn't choose just the good ones and we'll say it was a good paper. This one, there's a lot of lesson to learn from this one, just like the very good ones too. So any more questions? Okay, I see something in the chat box. I'm going to have to stop share and then go to, there's something in the chat box. Okay, Victor Collady says he's a medical student. Say everything interesting. I love the critical and constructive criticism of the paper. Obviously, I have learned and will continue to learn. Thank you so much for that. Yes, as we have all observed, there are a lot of tiny, and not so tiny things in the paper. But before we go to the technicalities of the clinical practice, Dr. Mubarak, as everybody has said, or anybody else, not necessarily Dr. Mubarak, what would you have suggested as the title for this article 1? And then 2, if you were to redesign the study, what would you have done? Dr. Mubarak, I hope you're still here. Or you want us to? No, we're not bailing you out. You are here to learn. Dr. Mubarak, you're trying to unmute, I guess. I don't know what is wrong today, but at least. So, Dr. Mubarak, what would your title have been? And if you were to redesign, if you were to design the study for your thesis, what would you have done? What would you do differently?
Before I go into the title, I think it should have been better as the study would have been better as a comparative study.
100%.
Maybe another, yes, maybe another established method of wound care in orthopedic patients.
Okay.
And then I wouldn't so far as to target complete healing of wounds, because as I mentioned earlier, some of these wounds are
sorry.
very
Let me just correct something. You only implied it, but I think it's good that you're explicit. You said you will not only target complete healing of wound, but I think what you meant to say, and correct me if I'm wrong, is you would not aim for complete healing by secondary intention.
Yes.
Good. All right, go ahead. That means, in other words, you will not allow, for those who are not medics, you're not allowed the wound just continue dressing until it heals on its own. It has its own drawbacks. Yes. Go ahead.
So I will possibly, my own aim will possibly be establishing a good granulation tissue for some of the wounds, or clearing of infection in obviously infected wounds.
Yes.
I think that would have been better, rather than just to aim for secondary intention in all of the wounds.
Or even like the use of honey in chronic orthopedic wounds where there's no plastic surgeon, because it's just apparent that you do not have a plastic surgeon.
Yes, obviously.
Which is the standard, that's what these patients will have benefited from. Go ahead.
Yes, ma'am.
So you have done a comparative study, you have compared another dressing agent, or even people with normal dressings without honey, because it's possible, it's something you can do. Just use you use honey dressing on one, and then you use the same thing in the control, but without the honey. It's possible.
Yes.
Even though ethically, I don't think that will scale through, because a patient has an infected wound. The patient has an infected wound because most of their wounds were infected, and you're dressing without an antimicrobial agent. That technically will not work. But let's assume they have huge wounds that are not infected with let's say, let's not say there's no exposed bone, huge wounds, and there's no infection. There's infection, but there's no exposed bone.
Let's see. What I'm saying is, I don't really just use the as the control.
Yeah.
The comparative study, what I'm comparing with should be something else, not really the absence of an antimicrobial, something else, probably the use of something like povidone iodine, which is also available here where we have them.
Yes.
So compare with the use of povidone iodine in healing of the wounds.
Okay.
To assess. And then for the honey, another aim in, if I'm to design this study, and one of the aims that I would one of the rationale for me to design such a study was to target the fact that honey is a little bit cheaper to assess compared to other branded products out there in the market used for management of wounds.
Yes.
So it's an easier thing to obtain and a cheaper thing to obtain. So my rationale would be to establish that, okay, despite the fact that it's cheaper and is more readily available, it will be good for our environment, especially this our environment that we have limitations to of access to some of these products. Okay. In fact, there are a lot that I've not even seen before. I've just heard it from someone, and a lot that I've not even had so far. So I'm still working my way through the title.
Okay. All right. Then, okay. So let's go back to our colleagues, the plastic surgeons. What would you have done differently, Dr. Akintayo, Dr. Atwebi, Dr. Maina? I'm going to ask all of you to unmute and then speak. What, all things being equal, we're talking Nigeria now. And if I'm not mistaken, I think they have a bigger health insurance system in Egypt. So let's come down to Nigeria now. After all, Nigerians forever travel to Egypt to go for treatment. So, but let's say Nigeria now, what would you do differently? I'm trying to unmute all of you. Let's speak so that Mubarak can go and tell his bone people that what they did was not right. Dr. Maina, I'm allowing you to mute. Dr. Akintayo, I'm allowing you to mute. Everything they have done, what would you have suggested otherwise? Please unmute.
Thank you very much, ma. I think it was just obvious that the clinical aspect of the management of these patients was done very badly. Because in fact, one of the patients that they mentioned actually had had a flap that necrosed. He had VAC, but because of exposed bone, then the orthopedic surgeons took over the patient. And apparently, from the way they did it, like the very moment they took over the patients, they are the ones that managed the patients till healing, which I think was wrong, and which Chief Akita had stated earlier, the fact that they did not tell us anything about the multidisciplinary management of this patient, because one of the patients actually explicitly stated that he had a rotational flap that they hissed. He subsequently had VAC, and then they now took over with honey dresses. I don't see why you should have VAC as a management modality, and then use honey you now use to complete the management of this patient. So that management pattern was outrightly wrong. So if they had told us that they had infected wounds, that they got clean with the use of honey, and then now had involvement of plastic surgeons or other surgeons that now subsequently came to cover the wound, that would have been better. But to use honey for a wound as a management for a wound as large as 20 centimeter by 13 centimeter or 17 centimeter is totally, I think, is not acceptable, irrespective of the environment in today's world, wherein obviously they may not have it may be that they don't have a plastic surgeon in their facility, but I believe there's a way that they would have closed the wounds better than use of honey, because just like you stated, man, those scars will end up being unstable scars because of the size of those wounds.
Exactly. The quality of those scars
breaking down.
Yes, the quality of those scars. I'm really worried about that.
Yes, ma'am. They showed us beautiful pictures now, but what happens in a couple of months down the line, which we will no longer see after this paper has been published. So that's the management modality was was just not it was not right in that regard. I think
Something
there was
else,
something else I wanted to
I was
say,
hoping.
but
Okay, go
I've
ahead.
forgotten it for now. If I remember it, I think I'll mention it back again. It was just related to the, but it's just slipped my mind. If I remember, I will mention it again.
I think I know exactly what it is you wanted to ask, because that's what I'm about to say. For that limb, I think it's that limb with the I don't remember what figure it is. I think it's the one with the
It's figure 2.
Elizarov frame that they said they
figure
did
2.
a rotational flap. And I
Yes,
looked at that limb and I was wondering where they would have, what kind of rotational flap they did
moved
in that area.
Okay, yes, ma'am.
Was it this one? Was it this one that they said
Figure
they
2,
used a
figure 2,
rotational
second
flap
one,
for?
the second one.
Okay.
The second figure,
okay.
Figure 2.
Okay,
So
next,
after
that's
this.
after this one. This is one.
Yes, ma'am.
I mean, where on earth
Is this one?
did this rotational flap come from, and how did they rotate it with the location of this wound? Or is it me that cannot picture it?
Yeah, the wound looks like it's almost half of the circumference of the limb, so I don't know where they picked.
I don't know. Exactly. I don't know what it is they're rotating. I don't know how they rotated it. So I think I can stop share now. And then, was anybody concerned about their use of antibiotics for 4 weeks? Antibiotics
well, maybe
for
Dr.
4 weeks.
Maybe Dr. Mubarak will answer that, because it is only in the setting of chronic osteomyelitis that I know that antibiotics go up to 6 weeks or even more than that. But for them to have used 4 weeks for management of patients, I don't know. They had as much as 21 smokers in the study, and 6
Arabs
diabetic
smoke
patients.
a lot. Arabs smoke a lot. So
the smoking, did the smoking or the diabetes influence the duration of the healing of this wound? It would have been very important. They should tell us. 6 diabetics. One of them was that she didn't tell us anything. Okay, 21 smokers. The other patients, it's like their wound healed earlier, but the smokers and diabetics, their wound were extended, stayed longer before. They didn't say anything along that line. They just lumped all their all the information together, and I think those were very important things that vis-a-vis. We've already talked about the fact that they didn't tell us the adjunct management that this patient had, because I don't want to believe that all this patient had on going home was just antibiotics, and then they told the patient relative to dress the wounds and then come back to them. They will show them how to dress it again, and then they continue till a wound will stay up to 15 weeks before it heals completely. So then in their wound management and dressing, they talked about debridement. Some patients had to read debridement. So there's something that I did not get from them when they now went to talk about results, which I don't think it was under results. They should have come to that. They should have still put it in their discussion. Now, some of the wounds that they closed post debridement, some of the wounds that they closed post debridement, is it that after the initial debridement, they dressed with honey and they were not able to close, or they dressed with honey, they closed, and they used honey on the scars? Because the way they did it from the initial section, some they braided and some wounds were able to close. So is it that they closed and they were not using honey to dress the scars, or all the wounds that they had, all the wounds that they managed had open wounds, some with exposed wounds, some without exposed wounds, and they used honey on them till complete healing? That was also not clear from the two discussions. But I think I'll leave it to my senior colleagues to talk about other areas. This is something that I still like in the back of my mind. If I remember it, I will mention. Thank you very much.
All right, thank you. So whilst I'm waiting for Dr. Akintayo and Dr. Osmaina to come on, let me just read out some of the suggestions that we have here in the chat box for the topic. Mrs. Salisu said, I would have suggested honey dressing, semicolon, a progressive way for orthopedic wound care. Yeah, that makes more sense. Mr. Jeremiah said, using the data presented, we can take a topic like effect of honey in orthopedic wounds, a case study of name of hospital in brackets. So yeah, that makes a lot more sense. And another thing, when we come to now the, Dr. Mena, okay, you're unable to unmute. I thought I asked you to unmute. Sorry, let me see where you are. Yes, please. Please unmute, Dr. Maina. I've asked you to unmute. Good. Thank you. Go ahead.
Thank you. I think I would like to look at this paper from two angles. One is the content of the paper, then the second is the presentation and arrangement of the paper.
Okay.
For the content, starting from the title, I really fully agree with the previous speakers regarding the title. The title could have been better. And I think some of the titles that were suggested in the chat box might have been better.
Yep.
What I'm not too sure is, with what they presented, it might have been better if they had a case series or a case report instead of what they set out to do, which basically would have been a comparative study. Because in their, if you look at the first paragraph, they said their objective was to evaluate the effectiveness and safety of using honey. So for you to do that, then it would be completely different from what they eventually ended up doing, which they just presented cases. Then the second part will be the issue of the presentation of the paper itself. I 100% agree with the pharmacist. And when she talked about the way the paper was presented, most of those things that were there in the methodology were supposed to have been in the results. And most of the methodology was actually missing. And that is why maybe we're having so many loopholes, and so many questions, because they didn't tell us how they went about selecting patients, their inclusion criteria, their objectives, then how they went about standardizing what they did, and then their endpoint. Nothing about that was said. So that's why we keep asking, and we'll not get the answers actually, because it's not there in the paper. So they should have, in the methodology, told us this is what they plan to do. This was how they planned to do it. Then in the results, told us these were their results. And then they can go ahead to now discuss, in the discussions, then talk about their conclusion. So I think the whole paper may have been better if it had been rejigged in a different way. Yeah. Then when it comes to the core issues on clinical practice, Dr. Atwebi has said a lot really regarding the management. Larger samples may have been better to justify what we hope to do. And then for honey, studies about honey, actually, there are standardized types of honeys you can use. Manuka honey is usually the standard that is used. But if you cannot use Manuka honey, then you can get one, subject it to what, if I remember, our lab scientist said initially. That is what you subject now, to compare the Manuka honey with your own honey, so that you can now subsequently use it. And that same honey should have been used for all the patients, because that's the only way we can confidently come out to say, no, this is what we've been doing in the past. Now we think we can change practice. Thank you.
Thank you so much. Mr. Samoa is here. He said something in the chat box, but I would like us to hear from him. That's another data scientist that we have. So our journal club is becoming richer every day. So let me just allow him to unmute, and then he will speak. So Samoa, I've allowed you to unmute. Please speak. Thank you. We can't hear you yet. You've unmuted, but we can't hear you. Good. We can hear you now. Morning, Asamoah. We can't hear him anymore. Whilst we're waiting for him to speak, as soon as he starts to speak, I'll keep quiet. So now, number one, the authors had their problems. The reviewers had problems for not picking that they jumbled up materials and method. They were putting results in there. And then the editor-in-chief, even though he hardly ever has much to do after the reviewer after the peer reviewers have reviewed and sent, but if he was a specialty, he's something he could have done. So I don't know how he scaled through those 2 steps and then got published. It would be interesting to see if the author, if the journal gets letters to the editors and there was anything written about this. We should probably, maybe we should task Mubarak, the reviewer, to do a letter to the editor. Dr. Mubarak, will you take up that challenge? And when you publish it, we'll bring it to this forum to discuss. Thank you. Asamoah, we still can't hear you. I think it's your network. And I think Dr. Akintayo wanted to say something too. Dr. Akintayo, did you want to say something? Dr. Akintayo? Okay, all right. So if there are no further comments, unfortunately, we can't hear Asamoah. I don't know what is wrong. Maybe his network, but I can just read out his comment. What he said was the authors could have also considered measuring the wound size within a defined interval for the treatment period. With that, he could have gotten enough data to establish some statistical significance. Additionally, other variables, in brackets, qualitative factors, such as itching, scar appearance, quality, then assuming they were using comparative study, then the study could probably recommend mixed method approach or addition of honey to existing methods where feasible. Then Ebele said the effect of honey dressing, I think she's suggesting a title, effect of honey dressing on the rate of wound healing, a case study of orthopedic patients in brackets, name of hospital. So I think this has been a really interesting session, and we're looking forward to having even more participation at other sessions. So thank you so much, everybody. It was really a pleasure having you. Thank you for a very robust discussion. We'll keep you abreast of our activities. Thank you so much. Thank you, Victor Kolade. Says it was a very interesting session. Thank you. If there are no further questions, I think we can close now. Thank you. Bye-bye.